I'm presenting to you a case of acute angle closure glaucoma with dilated pupil and zonular weakness who needs an emergency cataract surgery. Acute angle closure glaucoma is a blinding ocular emergency. Lens subluxations is quite common and the angle closure can't be aborted with laser peripheral iridotomy alone. Pupil dilations due to iris ischemia could leave patients with impaired visual acuity with glare. This is a 69-year-old housewife with a precious eye, referred for acute angle closure glaucoma with uncontrolled eye pressure. Subluxated cataract was suspected looking at the forward bowing lens with unevenly shallow anterior chamber. Her pupil was fixed dilated. Biometry revealed short axial length. A backup sclera fixated IOL was prepared. Start with a good peripheral cornea incision which has to be above the iris plane to prevent iris prolapse. Vision blue helps to visualize the usually thin capsule. Make sure adequate amount of high-density viscoelastic is injected to deepen the anterior chamber. Viscosyncolysis can be performed at this stage. Always start with a small CCC because the high pressure in the lens tends to radiate it. Notice that the anterior capsule wrinkles and the lens move with my pulse with capsulorhexis forceps. These are the signs of capsular bag laxity. Hydrodissection has to be good and complete. Gentle mechanical force can be applied to make sure the nucleus is totally separated from the capsular bag. Viscodispersive viscoelastic is used to protect the cornea endothelium. When doing phaco, try to minimize movement and rotation. Here I demonstrate a phaco flip technique where you first engage the lens segment and then flip it over and gently phaco aspirate the lens matters. The Sinskey hook here is to stabilize the eye by holding on to the paracentesis wound and to support the lens segment for phaco aspiration. Be careful with the lens capsule when doing irrigation and aspiration. A weak capsular complex is floppy and keep coming to your probe. If the capsular bag is unstable, you should stop here and insert a capsular tension ring first. Otherwise, you can proceed with irrigation and aspiration until the capsular bag is thoroughly cleaned. Fill the bag fully with viscoelastic. This is a pre-loaded capsular tension ring size 14 by Mosher. Inject it slowly and follow the curve of the capsular bag. And you can see it loads pretty easily. Sometimes the threading end is out of the bag and you can use a Sinskey hook to manipulate it in. Always choose an intraocular lens that you are familiar with for smooth implantation. Do not remove viscoelastic yet. Pull the iris to the center with a Sinskey hook, or you can use a microforceps to perfect the job if you have one. Here I want to demonstrate to you the technique of reducing pupil size with horizontal mattress sutures. First, pass the 10-0 Prolene suture with straight needle. From the nasal side, take a chunk of the iris tissue and then do the second pass on the temporal side of the iris. Now use a 27G guide needle from the paracentesis wound to bring out the needle. Then use the same guide needle from the cornea main wound to bring in the 10-0 Prolene sutures and do your second pass again at 1 mm superior to the earlier one. Now, pull the two sutures in gently until the nasal and temporal part of the iris is kissing. Then use a Sinskey hook to bring out the two suture ends through the cornea main wound and tie 3 single throw knots outside the eye. And we can now cut the two suture ends with a Vanna scissors outside the eyes. Oops. You see the spontaneous hyphema. Bear in mind, bleeding can happen in the angle after synecholysis. Now, repeat the same steps superior to the first mattress sutures. The beauty of this technique is that the surgical knots can be performed easily by bringing out the suture's end through the cornea main wound, and we can cut the suture with a Vanna scissors outside the eye. This is the end result of the surgery. The pupil is much smaller with a small opening near limbus like peripheral iridectomy. In this video, we demonstrated meticulous technique in phaco-cataract surgery in the case of acute angle closure glaucoma. We emphasize steps to preserve the capsular bag complex and strengthen it with a capsular tension ring. We also simplify the technique of iris repair by using 2 horizontal mattress sutures of Prolene 10-0 with straight needles. I thank you for your attention.